and having very severe pulmonary hypertension. My colleague will present the story.
Good evening all. This is a 44-year-old lady who underwent sinus venous ASD surgical correction with a rerouting of right upper pulmonary vein to LA in 2013 from Vijayawada. Her preoperative cath showed a PA systolic pressure of 81, diastolic of 21 with a mean pressure of 47 and a QPQS of 1.5. She developed severe postoperative pulmonary artery hypertension and she was put on dual pulmonary vasodilators. She presented to us with a dyspnea of assertion in VHA class 3 with some facial puffiness, pedal edema for the last 1 year. She is also a non-hypothyroid on thyroxine 75 microgram once daily tablet for the past 9 years. Pulmonary vasodilator wise, she is on sildenafil 50 milligram TDS and ambrisentan 5 mg OD. On examination, she is having a weight of 53.8 kg, pulse rate 90 per minute, BP 120 by 80, basal saturation of 97% on room air. Cardiovascular system examination, she is having elevated JVP around 6 cm above the clavicle with a prominent A and V waves. Apex BT is felt at the 5th left intercostal space 1 cm outside the midclavicular line. She is having palpable P2, grade 3 parasternal heave, split second heart sound, P2 is loud, ejection systolic murmur of grade 3 by 6 at left upper sternal border. On doing the 6-minute walk test, she is having severe effort intolerance. She covered a distance of only 130 meter and post 6-minute walk test desaturation, she desaturated to 93%. X-ray situs altus, levocardia, cardiothoracic ratio 65%, MPA is dilated, multiple endon vessels you can see in this X-ray, and also the hilar pulmonary vascular prominence with early pruning. ECG wise, sinus rhythm, PR interval is around 160 milliseconds, QRS axis 105 degree right axis deviation, right ventricular hypertrophy with a strain pattern, QR pattern in V1. Echo, this is the apical 4-chamber view showing grossly dilated right atrium and right ventricle. TR gradient, she is having a TR gradient of 115, indicating RVSP 115 plus RA. She is having a PR with gradient of 53. RV FAC is 19.2. TAPC is 13.9. RV free wall strain is -8. In view of that desaturation, we did a agitated saline contrast study, and it showed spilling over of contrast into the left side after 3 cardiac cycles. Regarding other investigations, CT pulmonary angiogram was not suggestive of pulmonary thromboembolism. Her NT-proBNP is 983, normal value is 125 for this age group. ESR is 13, ruling out SLE-like diseases. TSH 2.13 on thyroxine 75 microgram OD. Diagnosis, status for sinus venosus ASD closure plus rerouting of RUPV to LA in 2013, ASD patch intact, severe PH, dilated RARV, hypertrophied RV, moderate RV, systolic dysfunction, IVC congestion. Plan is AFR.
So we can see the presentation, but we cannot see the cath lab. But meanwhile, you said that the contrast appeared after third beat. When you gave the contrast, it appeared after the third beat. Shiva, what does, what are we trying to convey? Are we dealing with something else? Are we dealing with pulmonary AVMs?
Okay, Neeraj, what happened was this patient, this patient had a resting saturation of around 98%. She had a significant pulmonary hypertension on the routine echocardiogram. When we did a 6-minute walk test, we initially got a normal saturation, but later we got a lower saturation of around 93. So a couple of days ago, we did a contrast echocardiogram, and in the contrast, when with an agitated saline, can you go to the PowerPoint and just show that one picture again? Go back to the PowerPoint. Yeah, just keep showing that one. So what happened was, when we were appreciating this picture, when the right atrium filled nicely, then in the second images we did not see. So in some of the patients who have advanced levels of pulmonary arterial hypertension, very advanced pulmonary arterial hypertension, some amount of intrapulmonary neovascularizations, angiogenesis and all happens, and in advanced stages of pulmonary hypertension, they get into mild desaturation. So we were thinking that since it is not acutely filling in, it was possible that this may be an intrapulmonary level shunt. We are not thinking about pulmonary AV fistula as such, but it is seen in advanced pulmonary arterial hypertension to have a mild reduction in the saturations, and that is attributed to be due to intrapulmonary abnormal vasculogenesis.
I think
And but then, yes.
yeah, it'll be a good idea to have a review at the CT, particularly cuts down onto the liver. If I mean, it's always a good idea whenever we did the CT mentioned no pulmonary thromboembolism, but the mention of other things would be even benefit.
Yeah. So you're something like thinking about a possibility of aberrancy or something like that, right?
Secondary cause
or
of a
some
PH.
liver disease associated PAH.
Yeah.
So now, since the original diagnosis was a sinus venosus ASD in an advanced age lady who had a diagnostic cardiac catheterizations initially which showed 81 PA pressure systolic, we already knew that this is a lady who is having little higher pulmonary artery pressures for a sinus venosus ASD. So and with a step up of only 6% from the SVC to pulmonary artery, we knew that she was probably a borderline candidate who has been taken up for surgery, and immediately after the surgery was identified to have persistent worsening PAH. So this is probably a sinus venosus ASD which has gone on to pulmonary vascular disease right at the beginning, because the first PA pressure was 81 systolic and the first step up was hardly 6% only. So it's likely that the sinus venosus ASD was treated much treated than the correct age at which it should have been treated. Now the reason for bringing her into the lab was to study her PA pressures and then see if there may be a need for creating a septostomy to make a pop-off. But if you go by the history, there were possibly, there were probably not a definite episode of syncope. I just reviewed with Rohit, who is one of my colleagues who looks after all the patients with pulmonary hypertension. And he said, frankly, she doesn't have syncope. Her 6-minute walk distance is only 130. She gets profound fatigue at peak exercise and she stops. 6-minute walk distance of 130 is quite high and 960 pro-BNP is quite high. So she comes under the higher risk pulmonary hypertension group. So we wanted to study. Now, I'll just run through the pictures. Dr. Mahua is evaluating the intracardiac echocardiogram. What you see proximally is the right atrium. The intratrial septum is bulging into the left atrium. And can you go to the next picture, Dr. Mahua? So this is we did a contrast with the patient sheath inside. So you can appreciate that towards the superior edge of the atrial septal patch, there is some amount of contrast that is crossing over. Next picture. Then next. Then when we passed the wire passed through. You can appreciate here the guide wire was passing through, that possibly a PFO. Next. So this is the wire that is passing through. Next. So next. Okay, next. Until this point of time, she was in sinus rhythm. I'll show you next what happened. Next. Okay, so this is the atrial septum and the sheath is across. Now you can appreciate that she went into a flutter. So next picture. So she went into a flutter with the sheath across, and we were assessing the hemodynamics of the left atrium and the right atrium. Next picture. So you can appreciate the M mode of that LA appendage, the far field structure, which is showing a 2:1 flutter with the QRS complexes are on the top. So she developed a brief episode of flutter. What we did was, during this particular time, we gave her metoprolol 5 mg in order to find out whether she will just terminate with metoprolol alone. We kept our things ready for a cardioversion electrical, but she converted about a few minutes later into a normal sinus rhythm. Next picture. So this is the atrial flutter being documented. Next. Okay, right now as we speak to you, next. So this is the flutter. Now let me see whether I am, can you go live, Dr. Mahua? Live? Yeah, so now the sheath is across. The patient is no longer in flutter. The septal sheath is passing through the dilated right atrium into the small left atrium, and the sheath is across. Now the blood pressures are about 150 or so. We did the saturations were now we had realized that there is a PFO which is already possibly decompressing the right atrium. Now I will show you the simultaneous RA and LA pressures.
Shiva, can I make a comment?
Can you?
Dr. Dalvi
Yes,
wants
please.
to reserve. Yeah.
Really.
Yeah, Dr. Bharat.
Really, you told us that there was a PFO, but I was standing here for quite some time to make that comment. It is not uncommon
Yeah.
that when you do this kind of contrast from the upper limb, that you will not see the contrast come from the right atrium to the left atrium immediately in these pulmonary hypertensive patients. My belief is that the streaming from the upper limb is such that it tends to go more towards the RV, but the tricuspid regurgitation sends this, this contrast in a reverse fashion, which can then track along the PFO into the LA. So like in our usual normotensive PFOs, where you do a contrast study, it spills over almost immediately following Valsalva release. Sometimes in hypertensive, we have seen this happen, that the contrast might come after 2, 3, sometimes even 4 beats. So I wanted to make this comment that upper limb contrast in terms of sensitivity for PFO is not all that great.
Absolutely, I think I totally agree with you, and that is possibly what was responsible for that slightly delayed right-left shunt. And now we have a clear-cut proof that there is a PFO that through which our sheath has gone in, and this is the right atrial and left atrial simultaneous pressures make the pressure bigger. Now, because of her heart failure, actually her right atrial pressure is quite elevated. You see the right atrial pressure is almost around 22. And the left atrial pressure too is little on the higher side. The left atrial pressure also is now something like around 16. There is a, put it on 25 scales, put it on 25. Yeah, so there is a interatrial pressure difference of around 6 millimeters. However, both the pressures are quite high. One of the contraindication for doing a balloon atrial septostomy will be an RA mean pressure of more than 20. So we probably just are going to leave this PFO as such. I'll tell briefly the hemodynamics. The pulmonary artery pressure was 110 by 50 with a mean of around 75. Against aorta was also more or less the same systolic pressures. The aortic diastolic and mean were marginally higher. The PA systolic and aortic systolic were almost similar. It was about 110 PA systolic. So now, since we have a PFO that is possibly already decompressing the right atrium, even though her resting oxygen saturation was 98, 6-minute saturation dropped down to 93, and we have a couple of evidences that the saline contrast in the atrium is spilling onto the left. So we are going to come out of this now. She's already on dual pulmonary vasodilator. We will just continue with the pulmonary vasodilator. We are not doing a dilatation of this PFO in view of high right atrial pressures, because she will desaturate much more if I do a balloon atrial septostomy.
Since we are not proceeding with the AFR, can you guide us as to when we are doing, when we are taking a case for AFR, what parameters are you actually evaluating on echocardiography? Are you concerned about the distance between left atrial free wall and the interatrial septum distance? Is that a parameter which you rely, because you are going to puncture the septum, and
not such a,
and there's always a risk of
a bulky device. It's a sleek device. Dr. Uma Maheshwar is going to show the device, and it is actually a pretty sleek device. Now your question is, during the transeptal puncture, the septum is already bowing into the left atrium, and so whether you are going to be, the moment you prick the septum, whether you are the next minute the needle will go and injure the left atrial appendage wall or left atrial lateral wall. It is possible, and hence in these patients what we do is we give an increased needle curve. The second step is, as soon as we cross and enter the needle alone, and if you think that in fluoroscopy the needle has gone quite very close to the left atrial wall, we advance a 1/4 coronary wire, and after advancing the coronary wire, then advance the sheath so that we don't injure the left atrial posterior wall. Normally what we do is, the moment the needle enters, then the septal dilator is also pushed up so that you get a better anchor. But in these patients, if the fluoroscopy shows that you are quite deep, then you advance a coronary guide wire. So what Dr. Uma shows is the AFR. He's showing the central hole. So this is 8 millimeter, and he shows the waist, which is 5 millimeter. So this 5 millimeter is going to be depending on the thickness of the septum, In this patient, since there was a pericardial patch across the sinus venosus septum, we anticipated that it may be thick. In fact, we did not document the PFO before. We only saw it today on the intracardiac echo. And so we anticipated that it may be thick, and so we wanted a 5 millimeter thick 8 millimeter AFR, and this is the AFR. However, we are not using that because the RA mean pressure is high. Show the hemodynamics again. So the right atrial hemodynamics. Right atrial mean pressure is somewhere around 20. Left atrial mean pressure is around 13. There is a 7 gradient between RA and LA, and the systemic pressures are quite adequate. This is the systemic pressure. Show the aortic pressure. Her flutter has returned back to normal. She is in stable sinus rhythm now.
So our next
So
lab
we-
is
what
ready.
we'll
We
do
just
is we'll
got the
continue.
sorry to interrupt, Dr. Shiva. We just got the information. The next lab is ready. So if there is an additional message which we
Thank you.
need to okay. So we go on to the next case by Dr.
Nothing,
Varakan.
nothing. We are.
Okay.
Thank you.
Thank you for the demonstration. We can go on to the next case by Dr.